All right, thank you. There we go. All right, like Mark said, Jacob Hartnick, I did an ultrasound fellowship at North Shore. And I'm going to be talking about hocus pocus for small adults. And so I was asked to do a 15-minute lecture on this topic. And so I thought, what could I do that's pretty high yield that maybe I can get you to familiarize yourself with in 15 minutes? And so I decided appendicitis, because we see this all the time. And it's something sometimes our radiology departments miss. And we can diagnose it right there at the bedside, and we look pretty cool. All right, enough time, I suppose. All right, so we're going to start with the case. This is a HIPAA-compliant, slightly true case. You receive a sign on a 10-year-old male, presents with typical right lower quadrant pain. It's constant. It's non-migratory, so maybe it's not perfect textbook. And it started earlier that day. He appears pretty uncomfortable with sign-outs. You're doing bedside sign-outs. You say, you know what, this kid looks kind of sick. So you're told that he already went up for a radiology-based ultrasound, and you're going to follow up the result. And then, of course, you say, hey, I was here. What are you doing? And so during sign-outs, the radiology report returns, and limited, but kind of negative. And you say, wait a minute, this kid looks kind of sick. And I have a pretty high suspicion, so what should we do? So first thing you should probably do is go back and review the radiology images, right? See what they did. And so, I did that, and I said, you know what, they did get pretty limited images. And for those of you that are not so familiar, we got your muscles up here. It looks like it's some iliacs right here, psoas muscle. Here it's a sagittal view. Something here that could maybe be something positive, not so sure. But pretty limited images. So since your pretest probability is pretty high, you decide to grab the machine, right? So you decide to do some focus. So this is the worst nightmare for ultrasound lectures. Can you guys see the slides? I don't know if we can turn on these lights a little more, but I'm sure you can see the right side, and there is a anechoic tubular structure. You can see the measurement, right? The measurement measures over 1 centimeter. Is that good or bad? Bad, right? So over 6 millimeters, so we'll talk about that. And on the right side here, you've got your muscles again, iliacs, and then you can see, focus right here, there's this anechoic structure coming down, and it's dipping down right over the psoas and the iliacs, right? And so that's what the appendix looks like on ultrasound, so that's appendicitis. So you call the surgeons, and they come down, and they say, okay, you're right, this kid sounds like he's appendicitis, I guess we'll take him to the operating room. And so the final diagnosis is appendicitis. All right, so this kid could have been sent home on a negative ultrasound, or could have gotten CAT scan with more radiation, but you saved him from that. Right, so there's a perfectly good radiology department. Why should you, as emergency physicians or pediatric emergency physicians, learn how to do this, right? You can just send them up and go on to your next patient. You'll see more patients that way. One is, sometimes like this case, they miss it, and so you're going to get a CAT scan, which is not necessary, and radiation is bad, right? Somewhere in the 1 to 1,500, 1 to 2,000 increased risk of lifetime of a cancer from a CT of the abdomen. So, you don't want to be that person that gives a child cancer. All right. And kids are ideal, right? So this isn't Dr. Levitan's intubated patient that we're trying to ultrasound here, right? Because that's hard. Nobody's going to be able to do that. I don't think that person can fit in the CAT scanner either, but the kids are really thin, right? They're small. We have a really good probe that looks at thin structures with high resolution, right? So we'll talk about that, right? You want to use the linear probe a lot of the times, and if you can't find it with the linear, you can use the curvilinear. But the linear probe, the high frequency probe, is one that's going to get you the most bang for your buck. All right, it's right there. I'm sure every single one of you has an ultrasound machine in your department at this time, right? It's 2018, we've all got ultrasound machines. It's probably just sitting there, nobody else is using it. Why don't you grab it and take a look, see if you can find something. And we're good at it, right? So our studies are pretty good. The bedside ultrasound for appendix is pretty specific. Maybe not the most sensitive test, but pretty specific. And so if you can find it, you can go ahead and call surgery to come down and evaluate the patient. All right, so how do we do this? How do we look for the ultrasound on bedside ultrasound? How do we look for the appendix, on bedside ultrasound? So there's many ways to skin a cat, and there's many ways to look for the ultrasound, for the appendix. And so I'm going to show an approach that was taught during my fellowship by Dr. Tang over at Cohen's, who's a master at pediatric emergency ultrasound. It's TLC Go. All right, so the T stands for point of maximal tenderness. This is the big one. This is if you're going to do nothing else, you got to do this. And so you, if the child's old enough, obviously, have them point to their belly. Where does it hurt? And that's exactly where it plays a role. Lowest point, so you want to look down the pelvis. Sometimes these appendix are going to hide down there, right? We all learned in anatomy class that it can be all over the place. Coming off the cecum, it could be retrocecal, it could be in the pelvis, it could be coming across. So you want to look down on the pelvis. Then you want to find that cecum, right? It's got to connect to the appendix. So you want to look around the cecum. And then go fishing, right? Once you're done with the first 3 steps, you kind of just look around. All right? Good, these are showing up a little bit better. All right, so the first thing is, what are we looking for? We're looking for a blind-ended tubular structure, right? The appendix comes out, the cecum eventually ends, and then you're looking for that to be tubular. It's a nice tubular structure. It's usually distended in appendicitis, right? So on the right side here, you see how it's tubular, and on the left side, you've got this structure here coming into view, and it's going kind of slow, not sure why, but there's an appendiculate actually inside that. There's a little white with shadowing, and that's your appendix. And then you see as it keeps going, it goes away completely. And so you know it's blind-ended. It just stops. You can't follow it further. All right, that's a key. That's a key to finding the appendix. All right. Then here, again, you got your muscles here. Here's the peritoneum. And right here is this anechoic structure. And you can see it starts to look kind of like a target as we go through it. Maybe it's not that easily appreciable, but you can trust me. It looks like a target there in a transverse view. And that's because of the muscle layers, right? So the muscularis layer is anechoic. It's followed by the more hyperechoic submucosa, and then the lumen that's filled with fluid is going to be anechoic again. So it forms this nice little target sign. All right? And it can look differently depending on where you are in the disease process. So early on, maybe it's not so anechoic like the one we just showed, but as you go on towards grade 4 here, it's pretty gangrenous, so it can be kind of in between there. So it may look a little bit different. You're going to focus not just on the appearance and how dark or not dark it is, but also on these other things we're about to talk about. So what are the signs? So we already talked about blind-ended tubular structure, all right? But the key here is non-compressible. It's distended, it's sick, and so you can't compress it. All right, so in this view, you have an appendix that looks a little bit different from the ones we've shown already. It's a little more hyperechoic, but as you can see, everything is getting compressed, and this should be a lot faster, but everything's getting compressed except for that. That's really not changing its size as we try to push up and down in the belly. And this is gentle compression, right? Kids that have appendicitis probably not going to like you matching on their bellies. So gentle compression. All right, size matters, so greater than 6 millimeters in diameter. This is going to be a little bit smaller in infants. The appendix grows from about age 3 to 6, but in general, greater than 6 millimeters is going to be the key. Right, and you measure from the outside of the black to the outside of the black across. You can measure a transverse and sagittal view, but just remember outside of the black to outside of the black. Right, and no peristalsis, so the appendix doesn't peristalse. So if you see something, here's the iliacs, here's the psoas muscle, and if you see something, so this isn't, by the way, appendix, this is iliacs, and if you're confused, in real time you would see that it's pulsating, and you put color flow on it. But up here, you have like the structure you might think is appendix, but then you see it's moving, it's peristalsing, and so that automatically disqualifies that structure from being the appendix. And so once you find that thing that you think looks kind of suspicious, you track it back to the cecum. All right? And the cecum is going to have 2 types of appearance. One is it's going to be air-filled, like the rest of the colon is pretty air-filled. Sometimes it has a starry type appearance to it with little flecks of air in there. And so this appendix, you actually started off in the cecum, and then it's coming across the psoas muscle, which is here. I know it's a little tough to see. It comes across the psoas muscle towards the iliac vessels, which are popping into view right there. All right, you can also put color flow or power Doppler to see if there's hyperemia and see if it lights up all around, right? If the structure is sick, it's going to increase blood flow, and so it's going to be a little hyperemic. And then you can look for an appendiculate, right? Pretty pathognomonic for appendicitis. And so in this clip here, you can see a little white dot popping into view with the shadowing. All right, everybody catching that little white thing shadowing? Of course, this is the one that's going full speed and one that kind of want to slow down, right? All right, so the T, tenderness. So you let the child point you to the diagnosis. If they're old enough, I'll actually hand them the probe and say, hey, can you just put this where it hurts? Right? Oh, my video's not playing. Could have saw my daughter point her belly, but it didn't play. All right. You can hear her laughing. All right. And so once you point there, this is, by far, this is the one that gets me the diagnosis the most frequently. The searching is, I'm guessing here, but maybe 30%. But 70% of the time is going to be, you just put the probe right in the belly and they point you right to the diagnosis. All right, so think of the right lower quadrant as a box. So this is the lowest point of the box. Some of these appendix are going to hide down in the pelvis. So you got to look down into the pelvis. Right? Some of them are going to be, about 10% are going to be that way. And it's kind of hard to appreciate here, I know, but there's psoas muscle, and then you'll get the iliac vessels, and you don't see any bowel, any small bowel, any large bowel, anything that looks like an appendix. You don't see anything in between. And then you see the iliac crest down here. It's hyperechoic. And so that's how you know you're all the way down deep enough. Is because there's really no bowel around, you're just looking at the iliacs and the psoas muscle. All right, here's the psoas muscle, iliacs, this is our anatomy here, rectus, and the obliques. And that iliac crest we talked about right there. Right, and that's the same thing except now in ultrasound. The iliac crest, psoas muscle, iliacs, right, here's your obliques. All right, so if the pelvis is the bottom of the box there, the pelvic view, then your cecum is the lateral portion, right? So you go all the way over, find your ascending colon, which is going to be air-filled, and you follow it down. All right, and this up here, so this is psoas muscle, and up here is like this kind of pyramidal-shaped, starry specks of air in there structure, and that's your cecum. A lot of times the appendix will come right out. Go away, son. The appendix will go right over the psoas. All right, here again, you see the appendix coming off the cecum, going over that psoas muscle. So once you're done with the C, the TLC portion, you go fishing, right? So you look for secondary signs of gentle gradient compression. And what are these secondary signs? So the appendiculate that we already talked about is kind of a secondary sign. The hyperemia we talked about, when you put your power Doppler or color Doppler, that's also kind of a secondary sign. But you can see here, there's also a secondary sign here. There's black, right? So here's also a lot of black. That's bladder. You see how it's nice and circular? Free fluid triangulates, right? It doesn't look circular. So circular is cyst, circular is gallbladder, circular is bladder. It's not free fluid. But you see how this triangulates? It goes into the nooks and crannies of the bowel there. That's what free fluid looks like, and that can clue you in that there is appendicitis. This one is a really sick appendix, and you see how the omentum and the paraappendiceal fat is super hyperechoic? That doesn't look normal. If you do enough of this, you'll see that looks really abnormal. And so that's like hot fat around the appendix, and so that can also clue you in to look for the appendix a little bit further. Luckily, in that case, it's pretty obvious. All right, and so we don't have time to go over too much of the literature, but I just wanted to point out, if anybody's not been to the POCUS Atlas, it's a really great reference. The POCUS Atlas gives you a lot of good images, and it shows you some nice graphics that depict ultrasound and any other, actually not just ultrasound, but journals and results. And so this is a meta-analysis from the Journal of Academic Emergency Medicine, and you can see sensitivity is 86%. So if you have a high suspicion and it's negative, you probably don't want to stop there. You want to get another test. But if you find it, specificity is 91%, then in the high suspicion case, this is probably actually appendicitis. All right, so now you can go out and own the appendix. When you go back to your shifts, grab the machine and try it out. Right? If you find it, great. You can start getting the ball rolling on the treatment and management. Any questions?